But the fact is that things have changed quite a bit from when we started. And the fact is that today, most patients go into coronary angiography for the evaluation of chest pain or dyspnea or some sort of a suspicion of coronary disease actually don't have obstructive coronary disease. So this is a registry from NCDR, the ACC registry, and you can see that it's almost 400,000 people, and you can see here that 2/3 of them that went to coronary angiography did not have obstructive coronary disease. Since then, there's been so many other registries published, and you can see that over time, and there's interesting registries showing that over time, the rate of non-obstructive coronary disease have gone up year after year, both in men and in women. More prevalent in women, but men are quickly catching up on the same trend. Now, here's the bad news. I think this is actually of great concern. This was an AHA document that was published in May, and it shows predictions in the US through 2050 in terms of risk factor growth and what happens to cardiovascular disease events. And you can see that if nothing change, you will see that 60% of the US will be obese, and a similar number will be having hypertension. More than a quarter of the US will have a diagnosis of diabetes, and I would say a much larger number will have a diagnosis of prediabetes. And the only statistic that is going in the right direction is actually cholesterol lowering. We're getting very good at taking our statin and reducing, but we're not watching our diet, we're not exercising, so we're growing in size. And so I would say the cholesterol theory that everything is about cholesterol is rapidly changing, and we know that there's some residual risk that is not related to cholesterol, related to other factors that are continuing to promote the growth or the prevalence of cardiovascular events. And you can see here coronary heart disease going up, heart failure, stroke, and the combination. So I think this is what's coming. And I would say it's here today, but it's going to get much worse if we don't do interventions to change this trajectory. And so I think the recognition that the disease starts very early is now gaining momentum, because early intervention probably will prevent events. And I think you've seen this and you live this every day. So I think detection of plaque. And so now we have tons of companies that want to make money of this, right? But I think that's a fact that I think plaque burden quantification will be something that will see and patients and doctors will require for my patient to have tell me how much, what is the burden of disease, and maybe develop guidelines that are more targeted to how much plaque there is in the coronary circulation. And of course, there's a number of interventions that we can do to actually make prevention. So plaque, it's not that everything is about physiology. The anatomy continues to be a very important component. When you look at PET compared to everything else, looking at coronary disease, quantifying flow is the value proposition here. When you go for CABG, what's the value proposition of CABG? Getting a Lima graft to one of the vessels, right? The value proposition for PET is flow quantification. We can do exercise, with ammonia, in the future with flurpiridaz or other tracers. But if you don't have the flow, you're missing out on this opportunity to uncover what may be going on in patients who don't have perfusion defects. And you can see in this specific trial that quantifying flow was the most accurate way to really tell about flow-limiting coronary disease. And when you look, for example, at maladaptive remodeling of the heart, the concentric hypertrophy leading to dilatation of the heart, you can see that when you develop microvascular disease, those patients have a much higher likelihood of presenting back with heart failure and type 2 myocardial infarction. And in fact, when you look at these stages of remodeling, the flow is quite predictive of events only in the when you have adaptive remodeling. Once you cross that line, you lost the window of opportunity to risk stratify, and most of those patients have events, but the flow is no longer predictive because everybody has an abnormality. So we lose the window of how to intervene early. The same is true in chronic kidney disease and in aortic stenosis. So all the forms of pathologic hypertrophy share sort of the same sort of circle of events.